this meeting. A lot of you will not know Erica Colleen. I have had the honor of meeting her in Korea, and I can tell you she blew me away. Nothing to do with her appearance, but with her knowledge and her scientific background. She is going to be one of the leading upper limb academic surgeons in the world. And she's now going to challenge you, Yap, with questions related to your presentation. Erica.
Thank you, Professor Angus, for a wonderful and most delightful introduction for me. Dr. Williams, your talk is magnificent, but I have a few comments on your talk, which perhaps related to my background as the third generation of the shoulder surgeon, maybe. I would like to make a comment on the PJI, the prosthetic joint infection. So case number one, that guy has a flail shoulder at the end. And why you didn't do arthrodesis for the case number one? Can I know the reason?
The main reason that he had totally 6 shoulder surgery before, and he was really fed up with any other surgery. So I suggested him after removing the spacer to put in the reverse, but he refused. And that is sometimes the case in these failures, that patients had so many surgeries before. It starts with a fracture treatment, a redo for fracture treatment, and then it failed to remove the plate and do an adhesiolysis. And then the fourth is a reverse, and the reverse gets infected, and so on and so on and so on. So that is the cases I sometimes see, and they really are fed up with it.
Okay, so
Erica, if I could come in here, doing an arthrodesis in a case like this is really, really difficult because there is very little bone left to arthrodesis. And therefore, one alternative is to get a mold of the proximal humerus made and put that in as an interposition. But it's a really difficult situation. Back to you, Erica.
So a resection arthroplasty sometimes is the solution for for a severe shoulder joint problems. What do you think, Dr. Williams?
Yes. Well, I always offer the patient again a reverse, but sometimes a flail shoulder is acceptable, but generally the clinical outcome is poor, but the pain is depending, sometimes substantial, sometimes reasonable. So sometimes patients end up with a flail and they are happy, and sometimes they come back and say, please, can you do something? And then you can try another reverse arthroplasty.
Okay, I'm asking this because a prosthesis is very expensive in our country. So we do have a money problem too. A second question is a follow-up question for the case number 2, which is very related to case number 1. In the case number 2, that was a lady that really catch my eyes, that I only saw a few arthrodesis case. And that case, she had a multiple attempt of debridement and component revision. But the ending is arthrodesis, and patient was, I think, happy. I begin to think that perhaps arthrodesis is not as bad as I think and could be a feasible option for a complicated PGI, because I think I heard that an arthrodesis of the shoulder is actually a historical solution for the severe shoulder joint problems. Maybe it's not very historical. No. What do you think on this?
Yeah, well, I think in a certain aspect it is historical. When we didn't have a well-developed shoulder arthroplasty, shoulder arthrodesis was a very common procedure. But I think the only indication nowadays for a shoulder arthrodesis is neurological problem. And there's a complete flaccid shoulder due to involvement of all muscles around the shoulder. The shoulder arthrodesis is the best solution. And well, luckily, I had only 2 cases of shoulder arthrodesis after the failed reverse, But indeed, as Angus said, it is a difficult procedure. After that, after my case of arthrodesis, I had to do redo operation to add more bone to get finally healing of the defect.
Erica, can I interrupt you for a minute?
Sure, Professor.
I think Yap gave us a very good insight on prosthetic joint infection, but I would like to hear how John Sperling and Richard Page, they deal with this prosthetic infection. Any of you attempt single-stage revision surgery, or do you prefer staged revision as always?
Yes, for me, for an acute infection in a well-functioning prosthesis, I'll consider a poly exchange and a debridement. Unfortunately, most of the people that are sent to me are chronic infections, and then I tend to do 2 stages. I'd love to hear what Richard has to say and what the registry tells us.
So first of all, yes, an acute infection, but you want a favorable host and a favorable organism. So I would throw those caveats in. So in other words, a patient who it's acute, you can do a poly exchange. You've got first of all, you've got an organism isolated, and secondly, you've got a host who can stand up with the antibiotics and has got not too comorbid. Otherwise, I still err on the side of 2-stage, and often that first stage, you're actually waiting for extended cultures to get some of the difficult organisms we have to deal with around the shoulder, particularly C. acnes, but there's a whole range of other things that can be difficult to culture, particularly when there's been multiple surgeries, there's been intermittent antibiotics, etc. So I think following the Oxford protocol, which was, I think Yap alluded to, which is in that PJI link, is very important to, and the sensitivity and specificity is very specifically 5 samples for that. Taking more is actually decreases your the accuracy and the specificity of your cultures. In relation to the registry, John, what I can tell you is the results and the revision rate for revision for infection is over 30% and up to over 50%. So if you revise somebody for infection, the outcome is not good, but that's based on broad registry data.
So what about your experience in India, Ashish?
You need to unmute. Ash, unmute, please.
I agree with Richard. The revision of a infected prosthesis single stage is very likely for failure. Succeeded in 2 out of 10 patients, but it can come back anytime. It could be 3 or 5 years later. So a 2-stage revision is preferred. The difference between 1 and 2 stage is the functional outcome after a 1-stage revision is far superior than the functional outcome after a 2-stage procedure. But the result of control over the infection is far better in a 2-stage. So it depends on how fulminant the organism is. What intrigues me is that we don't see any infection from PJI as commonly as seen in the West. Most of our infections are Staphylococcus, if at all, and they're iatrogenic or coming from previous surgery. So K-wire fixations, previous surgery are more likely to get infected than primary reverse shoulder replacements.
And Professor, would you like to share your perspective?
Yeah, as John said, that in case of the acute infection, within 1 week of the symptom developed, I like to use the 1-stage polychange and massive debridement. But other than those kind of cases, I like to use, probably I do only 2-stage revisions. Usually it takes 3 to 6 months. I believe that laboratory exam and clinical symptom is much important than MRI. Usually MRI is really sensitive, so it looks still remaining bone infection or fluid there, but it's just reactive fluid or reactive change. So I don't believe the MRI, but believe the lab as well as the patient symptom. It takes 3 to 6 months after first surgery. That's my.
So Angus,
Richard, can I ask Richard? Oh, sorry. Can I ask Richard Page? you referred, Richard, to a favorable organism. Can you define favorable organisms and separate them from unfavorable?
Yeah. Favorable organisms are ones where there is not a broad resistance group, and and I guess that's a segue into the fact that this is a multidisciplinary disease. So involving our ID physicians is crucial in this. And secondly, that there is an oral step to equivalent sensitive antibiotic that you can actually take the treatment from an intravenous to an oral treatment tablet. Yeah, and it has to be treatment that is tolerated by the patient. So increasingly the resistant organisms, some of the antibiotics are still active, but the patients can't take them. So this is where you need the ID team.
Yap, you've been frozen out by the discussions going on, and it's only fair that we give you an opportunity to come back. Have you anything to say in relation to the discussion that's gone on, Yap?
Yeah, well, basically my philosophy is that in cases where there is a clear infection, as shown by aspiration or even radiography, I tend to do it one stage. But in cases when there have been infected hemis before, and I did a reverse after proper culturing, and my reverse is infected, so the more complicated cases, I tend to do it in the 2 stages. So that but it is not very scientifically, but mainly based on my experience. What will I expect? But yeah.
Sorry, can I ask you specifically in relation to acute infections, how much experience have you of using DARE, and was it successful?
Well, infection is very early, and the most case I've seen is when there, by coincidence, is a severe hematoma after the primary procedure, getting infected. They do very well with DARE.
Yeah.
As soon as you see a component lucency lines, you know there is a bacterial intrusion into the humeral shaft. And that is a severe problem, which will never be helped with the DARE. So the DARE is for an acute infection, even with a connection to the skin, and there is a sinus tract, but no loosening, then I consider a DARE.
And we've got 340 people attending at the moment. We need to guide them. And one of the things that I made a big mistake on in my early career is I did not intervene early enough in some of my cases, because you have to be convinced that you need to do something. What are the indicators, Yap, in your opinion, for going in early and washing out and possibly exchanging components?
Oh, I think that makes definitely sense. If you have a suspicion of an infection, which is not shown by whatever investigation, there's nothing wrong with going in and doing extensive rinsing of the cleaning of the and exchange components. I normally exchange my liner. I remove my glenosphere. I rinse very thoroughly both. I put in some gentamicin sponge between my base plate and my glenosphere. And I try, well, it is more difficult to do it between the liner and the humeral stem, but we are being very aggressive. That might be overdoing sometimes, but at least not under treatment these cases.
Thank you. And Erica, you have the last speech.
Thank you, sir. I have one very interesting question. Perhaps you might want to jump in as well. So during my fellowship with Professor John, he never let us touch the glenoid, the deltoid. The deltoid he will do by himself in every open rotator cuff repair. That is how he appreciates the deltoid. So my question is, if you have an unstable RSA, Dr. Williams, with a patient with a deficient deltoid, what do you do? Do you still proceed, or do you do another augmentation or reconstruction? These are the same question from Turkey, Professor Karim Bilsel.
You mean that when the deltoid is detached? Do you understand well, or?
Yeah, it could be very thin.
Yeah.
It could be detached, unfortunately.
Yeah. Yeah, well, if it has been detached previously, especially the anterior part in the deltopectoral approach, it is very difficult to reconstruct it. Sometimes you need some extra tissue. Sometimes I use an allograft fascia to making it a little bit more robust, and then fix it to the acromion and clavicle. And definitely immobilize for at least 8 weeks to get it better healed. And even sometimes I used an abduction brace to get a release of the deltoid to get it healed. But it's a very challenging problem. The same with the transdeltoid. If you do an improper deltoid, transdeltoid approach, and you have a detached anterior part of the deltoid, you have the same problem. To reattach it properly to the acromion is a challenge. So,
ladies and gentlemen, I'm going to wind up now because this is the time has run out for my section. I'm going to hand back now to Inho John and Ted Ma to conclude the meeting.
Thank you very much, all panelists, and it was an exciting meeting, and I can't believe we spent 2 hours for this webinar. And our president, Professor Ted Ma, will make a last closing comment.
Thank you so much, everyone. It's been an exciting webinar and a great discussion and interaction. Thank you all. I learned quite a fair numbers of tricks, and I hope you all too. I'd like to thank all the speakers, commentators, moderators, and especially you, the audience, for participating. And I thank Stryker for being sponsor. I'd like to thank Auto TV and Hannah Balim committee members and APOA Secretariat for the logistics and support for making this webinar possible. If you're not a member of this society, I really like to welcome you to join us as members. Please send your inquiry to us using the same email address or APOA online. In a few days' time, we will send you a quick survey for you to complete and return to us. Upon receiving the completed survey, we will forward the certificate of attendance to you. Finally, I'd like to introduce Professor Kim Bun Sang, Education Chair, to brief us about the next webinar to be held on the 31st of July this year, which is also the APOA Annual Congress. Mun Sang, would you like to introduce the next webinar? Or Margaret Falk, if you're there, Margaret.
Okay. Ted, can I introduce our next webinar?
Go ahead, Inho.
Okay, our next webinar is also a 3 sessions shoulder for SCR, which is a really hot topic these days, and elbow for osteochondritis dissecans, a common sports medicine issue. And we have an excellent guest speaker from Australia, Professor Gregory Bain. He's going to talk about Quebec disease. So you will have all the details and the information in our webpage.
Thanks for that. And to that end, this is the post-op webinar survey that we'll send you, but you can also log on yourself. Thanks again, everyone, for attending, and I say goodnight to you now. Bye now for all.
Thank you. Thank
Bye-bye.
you all.
Thank you.
Thank you. Thank you very much.
Thanks all.
Good day.
Thank you.
Thank you. Thank you.
Thank you very much.
Thanks a lot. Thank you. Thank you very much.